Usually when we talk about a medical diagnosis, there's this expectation of absolute precision. Like, it's almost like engineering.
Right. Yeah. Very black and white.
Exactly. Like if you
Yeah.
break your arm, you go to the hospital and the x-ray shows that jagged white line right on the screen. And the doctor just points to it and says, there it is.
Yep. The bone is broken or it is not broken. It's completely binary.
It's clean.
Yeah.
And honestly, I think as patients, we like things to be visible like that. We want our ailments to be easily categorized, easily measured.
Oh, absolutely.
But welcome to our deep dive today, where we are stepping into the world of sexual medicine. And let me tell you, that x-ray machine completely disappeared.
It really does. You are looking at a diagnostic landscape that is just incredibly murky.
Right. Because, if you are a scientist, how do you put a hard, statistically significant number on human pleasure? Specifically, like, how do researchers evaluate the subjective enhancement of climax intensity?
It is pretty much the definition of diagnostic muddy waters. We are taking one of the most subjective, deeply personal, and psychologically complex human experiences, and we're trying to force it into a spreadsheet.
It sounds almost absurd when you say it out loud.
It does, but clinically speaking, it is an absolute necessity. Because if we're going to develop effective medical treatments for sexual dysfunction, we have to be able to measure if those treatments are actually working.
Right, because if you can't measure it, you can't prove it to regulatory bodies like the FDA.
Exactly.
And that actually brings us to the core mystery we're unpacking for you
Yeah.
from our stack of sources today. We are looking at FDA regulatory frameworks, validation studies for these really wild psychometric measurement tools, and clinical trial data.
Lots of clinical trial data.
Yeah, everything from the placebo effect to literal stopwatches being used in male premature ejaculation trials.
Which is a whole fascinating tangent on its
Oh,
own.
we will get there.
Yeah.
But all of this data points toward a highly specific but massive debate in sexual medicine.
Right. The timeline debate.
Yes. When you are running a clinical trial to evaluate something as subjective as climax intensity and sexual satisfaction, what follow-up timeline is actually recommended by the science?
Do you measure the patient after 4 weeks?
Yeah.
Or, do you wait 12 weeks?
Exactly. 4 weeks versus 12 weeks. And more importantly, our mission today is to understand the underlying mechanics of why that timeline matters so much.
Because, as you'll see, human memory and human behavior do some very, very strange things when they are being observed.
So true. But I feel like before we can even debate the merits of a 4-week versus a 12-week timeline, we really have to look at how this data is being collected in the first place.
Yeah, the tools themselves.
Right. When I was reading through these validation studies, the tools stood out as a massive challenge.
They absolutely are. In this space, especially for women, the traditional gold standard has been something called the FSFI.
That's the Female Sexual Function Index, right?
Exactly. It's a 19-item questionnaire, and it basically attempts to quantify the experience by breaking sexual function down into 6 distinct domains.
Okay, knows the domains.
So you have desire, arousal, lubrication, orgasm, satisfaction, and pain. It's been highly validated over the years, and it is used constantly in clinical trials.
Okay, but then there's this other tool mentioned in our sources, which just operates on a completely different level. It's called the orgasmometer.
The orgasmometer. I know, it sounds like a prop from, a retro science fiction movie.
It totally does, like something out of a comic book.
But it's actually a very real, scientifically validated psychometric tool. It's built on what we call a visual analog scale, or a VAS.
Right, which people have probably encountered at a standard doctor's office, right? Like when they want to measure your pain.
Yeah, exactly. Where they ask you to point to a smiley face or a crying face to rate your pain from 1 to 10.
Right. But instead of measuring physical pain, the orgasmometer is designed to measure the subjective perception of orgasmic intensity.
Which is so hard to quantify.
It is. And the visual design they use is incredibly specific. It's this color gradient. It ranges from 0, which is colored completely white and represents absolutely no orgasmic intensity, all the way up the scale to 10.
And 10 is colored a deep, solid red, right?
Yeah.
Representing maximum intensity.
Exactly, white to deep red. But this is where we run into our first major mechanical hurdle in the data. Like, how do researchers establish the baseline for these tools?
Right, the recall period.
Yeah. When they validate the orgasmometer for men, they typically ask male patients to recall their sexual experiences over the previous 4 weeks. A 30-day recall period is, heavily utilized across these studies.
But our sources point out a pretty massive discrepancy here.
Oh, it's huge. Because when they were validating the female version of this exact same tool, the orgasmometer F for women diagnosed with female orgasmic disorder, or FOD, researchers did not use a 30-day window.
No, they didn't. They used a 6-month recall period.
6 months. That's half a year.
I know, it sounds crazy, but there is a strict systemic reason for that discrepancy. The researchers basically had to use a 6-month period to adhere to the diagnostic criteria set by the DSM.
The Diagnostic and Statistical Manual of Mental Disorders.
Exactly.
Yeah.
The DSM dictates that for an official diagnosis of female orgasmic disorder, the symptoms such as a significant reduction in orgasmic intensity, they must be present for a minimum of 6 months.
Wow.
So immediately you have this gaping chasm in how we are asking different groups to remember their own physical pleasure. You're asking one group for a 4-week memory and another for half a year.
Which honestly exposes the fundamental flaw of relying on memory for this kind of deeply subjective data in the first place.
Oh, absolute memory is terribly unreliable.
Right. And even if we throw out the 6-month requirement and just look at the standard 4-week window, that 30-day recall, our sources show that relying on a month-old memory is scientifically treacherous.
Yes. There is a fascinating study in our stack by Weinfurt and colleagues. It's titled Accuracy of 30-Day Recall for Components of Sexual Function and the Moderating Effects of Gender and Mood.
Such a long title, but the mechanics of what they've found are just staggering.
It perfectly illustrates why capturing subjective experience is so difficult.
Yeah. So, set up the study for us. What do they do?
Well, the researchers had participants fill out daily, real-time diaries of their sexual function for 30 days. So they're capturing the data exactly as it happens.
Okay, that makes sense.
Then, at the very end of the month, they gave those exact same participants a standard 30-day recall survey.
Right, the typical clinical trial method.
Exactly. And the goal was to compare the daily, real-time data from the diaries to what the participants remembered experiencing when they were asked at the end of the month.
And the results completely upend how we think about our own memories. Basically, the 30-day recall is intensely vulnerable to the person's concurrent mood.
Yes, their mood right at that exact moment.
Right. Meaning, the specific emotional mood you happen to be in on the exact day you sit down to take the survey drastically alters your memory of the entire previous month.
Precisely. The researchers used a tool called the Positive and Negative Affect Schedule to measure the participants' mood on the day of the survey.
Okay.
And they found that a person's positive affect, which essentially means being in a great mood on the day they take the test, that actually causes them to significantly overreport their ability to have a satisfying orgasm over the past 30 days.
Wow.
Yeah. The data showed an overreporting of 0.85 points on a 5-point scale.
Okay, let's unpack this for a second, just to put that into perspective for you listening. A shift of 0.85 on a 5-point scale is massive.
It is huge in statistics.
Right. Like, in a clinical trial for a new drug, a shift that large could literally be the difference between the FDA approving a medication and just throwing it in the trash.
Yep, it could make or break a billion-dollar drug.
And that shift is happening entirely because someone woke up on the right side of the bed that morning.
It's wild.
I mean, think about the last time you woke up in a terrible mood. If someone asked you to rate how good your life was over the last 30 days, your brain is just going to selectively hunt for negative memories to match your current vibe, right?
Exactly.
So, are you saying the exact same mechanism is happening here with climax intensity? Like, is using a 4-week recall to measure this stuff basically like asking someone to review a movie they saw a month ago, but their rating is completely hijacked by whether they are having a good or bad hair day today?
That is an excellent way to put it. And it aligns perfectly with the cognitive psychology concept of mood-congruent memory.
Congruent memory. Okay.
Yep.
How does that work?
Well, when you are in a positive mood, your brain essentially acts like a biased filing cabinet.
Yeah, okay.
It engages in a selective memory search, only pulling out the files that match the color of your current mood.
Wow, really?
Yeah. It is literally easier for your neural pathways to access memories of intense, satisfying orgasms because those specific memories align with your current positive emotional state.
The sources even point out that this positive mood might lead people to genuinely misremember specific sexual experiences as being far better than their daily diaries proved they actually were.
Yes. They aren't lying on the survey. They genuinely remember it being better.
Which is just crazy. Your brain is essentially rewriting the history of your own physical pleasure based on your current vibe.
And it's worth noting this isn't just a female phenomenon.
Right? Men do it too.
Yeah, the study noted that positive affect causes men to significantly over-report their erectile function over the past month, especially if their actual daily functioning recorded in the diaries was quite low.
Which creates this profound dilemma for clinical trials.
Mm.
I mean, if a 4-week memory is already this heavily corrupted by a person's current mood, how can we possibly trust a drug trial that relies on stringing these 4-week recall periods together?
Well, you can't. Not entirely.
Exactly. We know memory tricks the data, but our sources show that human behavior also tricks the data in the short term. Let's look really closely at the placebo effect for a minute.
Oh, this is where it gets really interesting.
Yeah. We have this incredibly detailed 12-week double-blind placebo study by Bradford and Meston. And they were studying women diagnosed with female sexual arousal disorder.
Right. And in this trial, the patients were given placebo capsules, literal sugar pills with 0 active medicinal ingredients.
Nothing in them at all.
Nothing. And they were told to take them before sexual activity. Then the researchers tracked their experiences using a tool called the Sexual Activity Record, or SAR.
Okay, what is the SAR?
It's basically a diary completed immediately after a sexual encounter. The goal is to measure whether the encounter qualified as a satisfying sexual event, which they abbreviate as an SSE.
Got it. And the patients on the sugar pill saw massive, statistically significant improvements, which is the classic placebo effect.
Absolutely.
But here is where the timeline becomes the entire story. The vast majority of the general symptom improvement happened in the first 4 weeks.
Right at the beginning.
Yeah. During those first 4 to 8 weeks, the raw total number of sexual events just completely spiked. But by weeks 8 to 12, that frequency dropped right back down to baseline levels.
However, this is the crucial part. While the quantity of sex dropped back down to normal as the trial progressed, the quality of the experiences changed over the full 12 weeks.
Right, the SSEs.
Yeah. The proportion of satisfying sexual events, those SSEs, jumped from 23% at baseline to 50.7% during the final 4 weeks of the 12-week trial.
That's wild. Over half of their sexual encounters became satisfying, up from less than a quarter.
Yes. All on a sugar pill.
All on a sugar pill.
Yeah.
And here is the detail that really caught my eye in this study. These women reported receiving much or very much genital stimulation during the trial compared to their baseline, even though their partners were completely in the dark.
Yep. The partners received no special instructions whatsoever to change what they were doing in the bedroom.
Okay, so if the partner isn't changing their technique, how is a sugar pill causing the women to report more physical stimulation? Is this like a psychological expectancy effect, changing their actual physical reality?
It really is. It is a prime example of heightened sensory vigilance driven by expectancy.
Heightened sensory vigilance. I love that term.
Yeah, I mean, when a patient takes a pill that they deeply believe is going to improve their arousal, they become hyper-focused on the physical sensations they're experiencing. Their brain is actively looking for evidence that the pill is working. And furthermore, taking the pill might increase their overall confidence, which shifts the communication dynamics with their partner.
Oh, that makes sense, like a confidence boost.
Exactly. The partner might not have been given explicit instructions by the researchers, but the patient's shifted attitude implicitly changes the entire encounter.
Okay, let me push back on how we use this timeline, though. If the raw frequency of sex spikes and the general symptoms show their biggest improvement right at the 4-week mark, isn't a 4-week follow-up just measuring the honeymoon phase of being in a clinical trial?
Basically, yes.
Doesn't the fact that the frequency drops back to normal, but the satisfaction remains high by week 12, prove that you absolutely have to wait out that initial spike to see real behavioral change?
You have hit the nail right on the head. A 4-week follow-up in a sexual medicine trial is heavily polluted by novelty.
Novelty, yeah.
You are simply measuring a placebo-driven spike in enthusiasm. The couple is having more sex simply because they are actively participating in a study and, taking a new pill.
It creates this artificial environment.
Exactly. But a 12-week follow-up allows that novelty to sort of burn off.
Okay.
When the sheer frequency of encounters returns to a normal baseline, researchers can actually see if there is a sustained subjective enhancement of sexual satisfaction that outlasts the initial excitement.
So regulatory bodies must be aware of this trap. Right. They can't just approve drugs based on a 4-week honeymoon phase, especially when we already know the 30-day memory recall is corrupted by mood.
Oh, they are very aware, which is exactly why regulatory bodies heavily mandate this 12-week evaluation period.
Okay, good.
The FDA frameworks included in our sources are really explicit about this. When they're evaluating drugs for conditions like female sexual interest arousal disorder, the FDA recommends what they call co-primary endpoints.
The co-primary endpoints, meaning they're looking for multiple things at once.
Right. They want to see a sustained improvement in those satisfying sexual events we talked about. A and D, a documented change in desire or arousal over the long term.
Ah, I see.
And they explicitly raise concerns about using existing instruments like the FSFI, specifically because of those known issues with recall periods and ever-changing diagnostic criteria.
And you can clearly see this 12-week standard operating as a filter in modern industry trials right now.
Yeah.
Like, our sources include clinical trial data from Derry Bioscience.
Yes, the sildenafil cream trial.
Right. They ran a phase 2b trial for a sildenafil cream. And just for context, sildenafil is the active ingredient in Viagra, but here it was formulated as a topical cream for women suffering from sexual arousal disorder.
And notice how they structured their measurement timeline.
Yeah, they specifically evaluated subjective exploratory endpoints metrics like arousal, lubrication, and the pleasure of orgasm at the 4, 8, and 12-week marks.
Very deliberate pacing.
So if I'm a pharmaceutical company like Derry Bioscience, I am basically forced to wait out that initial 8-week placebo honeymoon phase before I can even see if my topical cream actually works.
Right. That is exactly the clinical strategy. And for
Yeah.
them, it paid off.
Right.
It was only at the end of that full 12-week period where they saw the critical separation in the data. Basically, 48.7% of subjects using the sildenafil cream reported increased overall satisfaction compared to 42.6% of subjects on the placebo.
Okay, so they needed that full 12 weeks to let the behavioral noise settle, allowing the true efficacy of the drug to emerge from the shadow of the placebo effect.
Exactly.
So we've talked a lot about female sexual dysfunction and measuring subjective satisfaction. But how does this apply to men? Like, when we look at trials for male sexual dysfunction, specifically premature ejaculation, or PE, does this 12-week rule still apply?
It does apply, but the contrast in how they actually measure success is just fascinating.
Oh, totally.
The PE trials also utilize that crucial 12-week intervention period, typically following a 4-week baseline measurement. However, their method of data collection completely abandons the subjective surveys we've been discussing.
It is entirely different. They aren't asking the men to use a color-coded orgasmometer to measure the intensity of their climax.
No orgasmometers here.
No. They rely on a highly objective measure called the IELT, the intravaginal ejaculatory latency time. And to capture this data, the partner literally uses a stopwatch.
Yes, a literal physical stopwatch. The partner starts the clock at penetration and stops it at ejaculation.
Wow.
It is a strictly objective, time-based metric. They are replacing subjective memory with hard numerical timekeeping.
But inside these stopwatch trials, there's a biological phenomenon the sources highlight that completely skews the data.
Oh, the coping strategy, yes.
Right. Researchers found that some men naturally develop a coping strategy where they engage in repeated sexual intercourse in a single day. And because of the male refractory period, that second session drastically increases the latency time on the stopwatch.
It is essentially a physiological hack.
Right.
The male refractory period is the recovery phase immediately following a climax. And during this window, the central nervous system downregulates.
Meaning it sort of shuts down a bit.
Yeah, the responsiveness of the nervous system is temporarily diminished. So if a man initiates a second sexual encounter shortly after the first, his physical control is artificially heightened because his nervous system is still in that suppressed recovery state.
And so the stopwatch naturally runs longer.
Exactly.
The sources cite a study showing just how powerful this central nervous system downregulation really is. For men without PE, their average IELTS jumped from 10.3 minutes in the first session to 15.2 minutes in the second session.
That's a huge jump.
Almost 5 extra minutes. And this strategy significantly helped the men diagnosed with PE last much longer as well. But wait, so what does this all mean? If men in these PE trials are using a stopwatch for 12 weeks to measure literal seconds, Aren't we completely losing the subjective pleasure aspect that the orgasmometer was designed to capture?
Well, yes.
Like, does longer time always equal a better climax? Isn't that like trying to review a fine dining meal by timing exactly how long you chewed your food instead of, measuring how much you actually enjoyed the flavor?
That analogy perfectly captures the ultimate tension in sexual medicine right now.
Yeah.
Researchers are constantly trapped in this tug of war. On one side, you have objective physical data like a 12-week average of literal stopwatch times. On the other side, you have subjective psychological data, like a 4-week recall of climax intensity that we know is heavily influenced by whether you had a good cup of coffee this morning.
Right, the mood-congruent memory.
Exactly. A longer time on the stopwatch does not inherently mean a better, more intense climax. In fact, if a patient is intensely focused on maximizing the time on a stopwatch, they might become completely disconnected from the subjective pleasure of the experience entirely.
Wow, yeah. So, bringing this all back to our central mission for you, the listener, we started by asking, what clinical follow-up timeline is actually recommended when researchers need to evaluate the subjective enhancement of climax intensity?
And the consensus across the regulatory frameworks and all the clinical trials we looked at points clearly to a dual approach.
Okay, break that down for us.
Well, a 4-week follow-up is universally necessary to establish a baseline. You have to know where the patient is starting. But as we have explored, that 30-day recall is highly susceptible to current mood. And the behavior during those first 4 weeks of any intervention is basically flooded with novelty, expectancy, and the placebo effect.
So the 12-week follow-up is the scientific gold standard here.
Yes, absolutely.
The 12-week timeline acts as a necessary filter. It burns off that initial 4-week placebo spike, right? That sudden rush of having more sex and paying more attention to physical stimulation just because you were in a trial.
Exactly. It burns off the honeymoon phase.
Yeah. It gives the data time to breathe, allowing researchers to see if there is a true, sustained increase in the percentage of satisfying sexual events. It really is the vital difference between measuring a temporary surge in enthusiasm and proving a long-term shift in the actual quality of the experience.
Exactly. It forces the subjective data to stabilize before any real clinical conclusions are drawn.
But looking at all of this evidence, there's one provocative thought that really stuck with me as we were prepping this deep dive.
What's that?
Well, we have learned that our memories of sexual satisfaction and how they rate the intensity of our own climax are incredibly vulnerable. They're easily overwritten by the mood we just happen to be in weeks later.
Right. The mood-congruent memory effect we talked about.
Exactly. So, if our perception of our own physical pleasure is that flexible, could the ultimate treatment for certain types of sexual dysfunction rely a little bit less on changing the physical mechanics of the climax itself?
Oh, that's an interesting angle.
Right. Like, if subjective reality is dictated by memory, and memory is dictated by mood, could we treat dysfunction by therapeutically shaping how we emotionally encode and remember that experience the next day?
Wow.
If we can train the brain to only pull the positive files from the cabinet, could we effectively rewrite the subjective narrative of dysfunction without ever touching the physical mechanics?
That is a profound question to walk away with. I mean, if the measurement of the cure relies entirely on a mood-dependent memory, then treating the patient's mood might be just as effective as treating their body.
Which takes us right back to where we started today. When you look at an X-ray of a broken arm, the bone doesn't magically look healed just because you were in a good mood.
No, it definitely doesn't.
The X-ray is fixed. It's binary.
Yeah.
But in the world of sexual response, the image changes entirely depending on how you feel when you look at it. And trying to measure that shifting image might just be the most complex diagnostic challenge in modern medicine.